So if you watch basically any medical drama or, an action movie, you see it all the time.
Oh, yeah, the classic ambulance scene.
Right. Someone gets pulled out of a burning building, they're on a stretcher, and a paramedic just casually slaps a little plastic oxygen mask on their face.
Yeah, it always looks as simple as, like, handing someone a glass of water.
Exactly.
Yeah.
Just this throwaway action to show, hey, medical things are happening now, but we're doing a deep dive today that completely shatters that image.
We really are. The materials we have are eye-opening.
Yeah, we've got this literal clinical skills evaluation sheet, which has the exact grading rubrics medical students have to pass, plus this incredibly detailed medical infographic mapping out all the different oxygen masks.
And the mission for this deep dive is to take you, the listener, directly inside the mind of a first responder.
Put you right in their boots.
Right. We want to decode this really precise, life-saving choreography that goes into administering oxygen when literally every second counts. Because we have to stop thinking of oxygen as just fresh air.
Yeah, that's the big paradigm shift here.
It is. You have to start recognizing it as a highly potent, highly reactive medication.
Okay, let's unpack this because that's a massive conceptual hurdle right out of the gate. Looking at this clinical skills sheet, it lists the therapeutic effects of oxygen exactly like a pharmacy insert for a prescription drug.
It really does read like one.
It says it diminishes respiratory distress, prevents hypoxia, which is when your tissues are basically starving for oxygen, and improves cellular function.
But then you get to the safety rules.
Right. The safety rules read like a hazmat protocol. The one that immediately jumped out to me is this absolute ban on petroleum-based products.
Oh, yeah, the chapstick rule.
Yes. No chapstick on the patient, no Vaseline, no medical tape anywhere near the valve. I mean, why is something as mundane as sticky tape or lip balm suddenly treated as a severe hazard?
Well, so the physics of pure oxygen completely changed the rules of engagement. Like, the room air you and I are breathing right now, it only contains about 21% oxygen.
Mostly nitrogen, right?
Exactly. But the cylinders that first responders carry, those contain 100% concentrated oxygen, and it's under extreme pressure.
Right.
And while oxygen itself doesn't technically burn, it is a ferocious oxidizer. So it dramatically lowers the ignition temperature of other materials and, accelerates combustion.
So a substance that might normally just melt or smolder, like the petroleum jelly in lip balm.
It suddenly becomes highly combustible when it's bathed in pure oxygen.
Wow.
Yeah. It basically turns into rocket fuel. The friction of the high-pressure gas rushing out of the cylinder valve can actually generate enough localized heat to cause those petroleum residues to spontaneously ignite.
You're kidding.
No, it creates a catastrophic flash fire. So that's why the evaluation sheet mandates that cylinders must be secured so they don't tip, valves have to be closed even when they're empty, and obviously, absolutely no smoking.
So you're managing a highly volatile pressure vessel, not just a standard medical device.
Precisely.
And the physiological risks they outline here are just as intense. Like, the source material mentions oxygen toxicity, which happens if you deliver more than a 50% concentration of oxygen for several days.
Right, which causes cellular damage in the lungs.
But the craziest, most counterintuitive risk in these documents involves patients with chronic obstructive pulmonary disease. COPD.
Yes. The hypoxic drive.
Yeah, the sheet has a massive warning about it. What is going on there?
That is honestly one of the most dangerous paradoxes in emergency medicine. To understand it, we kind of have to look at how the human brain regulates breathing.
Okay.
So in a healthy person, the central chemoreceptors in your brainstem are constantly monitoring the acidity of your blood. And that acidity is driven by carbon dioxide levels.
So CO2 is the trigger.
Right. When CO2 builds up, your brain tells your diaphragm, hey, take a breath and expel this. We don't actually breathe because we need oxygen. We breathe because we need to get rid of carbon dioxide.
Wait, really? I always thought it was an oxygen thing.
Nope. It's a CO2 waste management system, basically.
But the text notes that COPD patients have chronically diseased lungs, so they are always retaining carbon dioxide.
Exactly. Their baseline is totally skewed.
Yeah.
And because their CO2 levels are always elevated, those receptors in the brain eventually just get blunted.
They just give up.
Pretty much. The brain gives up on using carbon dioxide as the trigger. So the body shifts to this backup system called the hypoxic drive.
Which relies on what?
It relies on peripheral chemoreceptors in the aorta and carotid arteries. And these sensors monitor oxygen levels, not CO2. So for these COPD patients, the only signal keeping them breathing is the fact that their blood oxygen is low.
Oh, wow. So if a paramedic encounters a COPD patient in distress,
Yeah.
and they just blast them with 100% pure oxygen, they artificially spike those blood oxygen levels.
Exactly. And those peripheral sensors say, hey, we have plenty of oxygen, no need to breathe, and the brain literally switches off the respiratory drive.
That is terrifying. You could accidentally cause a fatal respiratory arrest by giving a dying person the exact thing they seem to be starving for.
It's a huge physiological trap. You're trying to save their tissue from hypoxia, but over-treating them kills their neurological trigger to breathe.
Which explains why oxygen has to be dosed with such extreme precision.
Absolutely. It needs specific indications, careful titration, constant monitoring.
Well, if oxygen is this volatile chemically and this dangerous physiologically, it completely reframes the mechanical setup of the tank for me.
Oh, the set of choreography is intense.
Yeah, looking at the next section of the clinical skills sheet, the grading rubric demands that medical students do the equipment setup in a really rigid top-to-bottom sequence.
They cannot deviate from it.
Right. So step 1 is BSI, body substance isolation, putting on gloves and standard precautions.
Because the first rule of emergency response is, preventing yourself from becoming a secondary patient.
Exactly. But the tactile mechanical sequence that comes next is what's really fascinating. Step 2 requires the provider to inspect the equipment before they even touch a valve.
Right. They have to check the heavy metal cylinder for dents or corrosion.
And they check this thing called the hydrostatic test date stamped into the metal. Let's clarify what that actually means, because it highlights the extreme physical forces we're talking about here.
Yeah, let's put that into perspective. A full D cylinder, which is the standard portable green tank in medical bags, holds oxygen at roughly 2,000 pounds per square inch.
2,000 psi.
Right. To give you a mental model, that's like taking the weight of a small car and concentrating it onto an area the size of a postage stamp.
That is insane. So if the structural integrity of that metal casing fails, it literally becomes a bomb?
Exactly. So to make sure the cylinder can handle that violent force, inspectors periodically empty it, put it inside a water-filled jacket, and pressurize it with water way past its normal 2,000 psi capacity.
Because water doesn't compress.
Right. So any expansion of the metal tank will displace the water in the surrounding jacket. And if the metal stretches too much and doesn't snap back to its original shape,
The cylinder is condemned.
yeah, it's taken out of service. So first responders are trained to verify that this hydrostatic test date is current before they ever open the valve.
Okay, so they inspect the tank, then they have to inspect the regulator. They're looking at this tiny rubber O-ring to make sure it isn't cracked, verifying the metal alignment pins are intact.
Crucial steps.
Which brings us to step 3 on the rubric, which uses this incredible term, cracking the cylinder.
It sounds like opening a cold soda at a barbecue.
Right, but what they do is briefly twist the main valve slightly open and immediately slam it shut. And the sheet says this clears out dust and debris.
Yeah, it does.
But I want to ask, is this mechanical sequence inspect, then crack, then attach the regulator? Why is it so inflexible? Like, why not attach the regulator first?
Because it's a deliberate chain of survival engineered to stop cascading failures. Think about the physics of taking gas at 2,000 psi and forcing it through a microscopic opening. If a provider skips the cracking step and just attaches the regulator, any microscopic debris sitting in that valve isn't just dust anymore. It becomes a high-velocity projectile.
Oh, because of the pressure behind it.
Exactly. Plus, the rapid compression of gas entering the regulator generates a massive spike in temperature. It's called adiabatic compression.
Wait, so if there's a tiny piece of lint trapped in there?
That sudden heat and pressure spike could ignite it. You'd get a flash fire inside the regulator itself
So they're holding it.
while you're holding it. Or, even if it doesn't ignite, it shoots that debris directly into the delicate internal diaphragms of the regulator and just destroys the mechanism.
Or shoots it straight down the plastic tubing into the patient's lungs.
Exactly. So you must crack the valve to blast that debris out into the room air first.
And the logic just continues down the chain. Like, you can't check the tank's pressure until the regulator is securely attached.
Right.
But you can't attach the regulator safely unless you've already visually confirmed the O-ring is flawless.
Because if that tiny piece of rubber is missing, opening a 2,000 psi valve just results in a catastrophic screaming leak.
You lose the ability to treat the patient, and you drain your whole finite oxygen supply in minutes.
So that sequence, BSI, inspect, crack, attach, open, check pressure. It's a masterclass in risk mitigation. Every step validates the safety of the next step.
Okay, so once the tank is safely pressurized and cleared of debris, we face the next hurdle, actually delivering the specific dose of medication to the patient.
This is where that medical infographic comes in.
Right, it maps out this whole golf bag of different oxygen delivery devices. The provider has to pick the right mask and pair it with a highly specific flow rate measured in liters per minute, or LPM.
Because the goal here is to manipulate the FiO2, the fraction of inspired oxygen.
Room air is 21%.
Right. And the clinical objective is to bridge the gap between that 21% and whatever the patient's specific metabolic deficit is.
So at the very bottom of the dial, we have the nasal cannula, those
Yeah.
two little plastic prongs that go in the nostrils.
Very cool.
The infographic says it's for mild respiratory distress, flow rate strictly between 1 and 6 liters per minute, delivering maybe 24 to 44% oxygen.
Yeah.
But the restriction to 6 LPM stands out. If a patient feels like they aren't getting enough air, the instinct would just be to crank the dial up to 10, right?
You would think so, but the limitation is purely mechanical and anatomical. The nasal passages are lined with delicate mucous membranes that warm and humidify the air.
Okay.
If you push dry, high-velocity oxygen through those narrow prongs at anything higher than 6 liters per minute, it physically strips the moisture from the mucosa.
Ouch.
Yeah, it causes severe drying, painful nosebleeds, sinus damage. The physical limits of human anatomy dictate the ceiling of that specific device.
So to deliver higher volumes without causing trauma, you have to switch the delivery mechanism entirely.
You need a mask.
Right. The infographic details several masks covering the nose and mouth. The Venturi mask is super fascinating because it requires a flow of 4 to 10 liters per minute, but it delivers highly precise FiO2 levels between 24 and 55%.
The precision on that one is amazing.
How does a plastic mask dial in a percentage that perfectly?
It's an engineering marvel based on a Bernoulli principle. As the pure oxygen flows through a narrow constriction in the mask's attachment, its velocity speeds up dramatically.
Oh.
This high-speed jet creates a localized drop in pressure, like a vacuum effect, that pulls in ambient room air through specifically sized ports on the side of the valve.
So by swapping out these little colored valves with different sized holes, the provider mathematically dictates exactly how much room air mixes with the pure oxygen,
Exactly, before it ever hits the patient's lungs.
which makes it ideal for those COPD patients we were talking about earlier.
Oh, perfectly suited. You can administer the oxygen they need while carefully avoiding those massive spikes that trigger respiratory arrest.
But what about when a patient is in severe distress? The dial goes up again, and we get to the non-rebreather mask, or NRB.
That's the heavy hitter.
Yeah, requires 10 to 15 liters per minute, delivers up to roughly 90% oxygen, and it has that plastic reservoir bag hanging off the bottom.
Right, and the clinical skills sheet places a massive emphasis on a single requirement for that bag.
Yeah, the provider must pre-inflate that reservoir bag with oxygen before putting the mask on the patient's face. Why is that step so critical?
It all comes down to the mechanics of human inhalation. When a person in severe distress takes a deep, panicked breath, their peak inspiratory flow rate can easily exceed 30 or 40 liters per minute just for a fraction of a second.
Wow, that much.
Oh yeah. So even if the oxygen tank is cranked to 15 liters per minute, the continuous flow from the wall just cannot keep up with that sudden, massive vacuum created by their lungs.
So without the bag, the patient would just suck in room air from the gaps around the mask.
Exactly, which dilutes the pure oxygen and totally defeats the purpose of the treatment.
Ah, so the reservoir bag acts as a staging area.
Right. By pre-inflating it, the provider ensures that when the patient takes that massive, frantic gasp, they are pulling from a reserve of highly concentrated oxygen.
And then the bag just refills between breaths.
That's excellent.
Finally, at the absolute top of the dial, we reach the bag valve mask, or BVM.
The ultimate intervention.
Requires a massive 15 to 25 liters per minute, delivering nearly 100% pure oxygen. And this is used when the patient is apneic, meaning they've completely stopped breathing.
Right, or they're in total respiratory failure. The provider uses the self-inflating bag to manually force the gas into the lungs.
So at this stage, the provider has essentially become the patient's respiratory system.
They're breathing for them.
Yeah.
And that extreme flow rate just ensures every forced breath delivers maximum therapeutic benefit.
The staggering amount of critical thinking required here is just profound. Like, a provider arrives on a chaotic scene, manages an explosive high-pressure cylinder, navigates physiological traps like the hypoxic drive, and calculates fluid dynamics to select the right mask.
All in the span of maybe 30 seconds.
Right. And understanding this on paper in a quiet classroom is entirely different from executing it on, wet asphalt at 3 a.m.
Which brings us to the final puzzle piece in these sources.
Yes, how the grading rubric actually forces medical students to perform under stress.
Because the rubric doesn't just evaluate physical competency.
Right.
It evaluates cognitive control.
Yeah, the evaluation sheet includes this mandatory what to say out loud exam script. Students are required to physically narrate their actions in real time to pass.
They have talked themselves through it.
Yeah, they have to stand over the equipment and verbally state, I am taking standard precautions and applying BSI. I will crack the oxygen cylinder briefly to clear debris.
And if they do the physical action but forget to say it out loud,
they lose points. It's like casting a magic spell where the words have to be spoken into existence for it to count. Why force them to talk to themselves like this?
well, it actually borrows heavily from industrial safety techniques, specifically the Shisakanko, or pointing and calling system, that was pioneered by the Japanese railway industry.
Oh, pointing and calling, okay.
Right. In a high-stress environment, your brain is flooded with adrenaline. The amygdala, which processes fear and survival instincts, just takes over.
Which leads to tunnel vision.
Tunnel vision, degraded fine motor skills, all of it. Your brain is essentially screaming, just do something fast.
And that's when catastrophic corners get cut.
Exactly. So by forcing out loud narration, the rubric trains cognitive compliance. When a provider speaks their intended action out loud, they're actively engaging the motor cortex, the visual cortex, and the language centers of the brain all simultaneously.
Wow. So it forces the logical part of the brain to stay online.
Yes. The prefrontal cortex has to remain fully engaged with the hands. It prevents the provider from zoning out and relying on sloppy muscle memory.
You have to intellectually commit to the action before your hands are allowed to do it.
It creates a really powerful neurological anchor. When the chaos hits, that trained script overrides the panic response. Inspect, crack, attach, open, check.
It grounds them in the unyielding physics of the equipment.
Exactly. Keeping them from making a lethal mistake just because they're rushing.
And the final step on that rubric really reinforces the ongoing nature of it all. I am confirming oxygen delivery and continuously reassessing the patient's respiratory status.
Administering the drug isn't the finish line, it's the starting gun.
You have to constantly monitor how the patient's neurology and physiology are reacting.
The treatment never truly ends until the patient is handed over to the hospital.
So what does this all mean for you listening to this right now? I think the biggest takeaway is just profound shift in perspective.
You'll never see it the same way again.
No, absolutely not. The next time you see an EMT adjusting a green tank at the scene of an accident, or a nurse gently placing a nasal cannula on a loved one in a hospital room, you're going to see right past that simple plastic tubing.
You'll recognize the invisible, mathematically precise checklist running through their minds.
At lightning speed, you'll understand they're managing a 2,000 psi pressure vessel, calculating Bernoulli fluid dynamics, and navigating complex physiological paradoxes, all to keep that patient safe.
It's a phenomenal display of controlled urgency. But, as we wrap up this deep dive, there's a final real-world scenario we really should consider.
Okay, what is it?
Well, it's a scenario built entirely on the conflicting rules within our sources. We established earlier that for COPD patients operating on a hypoxic drive, blasting them with pure oxygen can eliminate their trigger to breathe.
Right, the lethal paradox of over-oxygenation, leading to fatal respiratory arrest.
Yet the very same clinical skills sheet dictates an absolute uncompromising rule. If hypoxia is suspected, high-flow oxygen is always indicated. There are 0 contraindications for a patient showing active signs of severe oxygen starvation.
Always indicated. Okay, I see where this is going.
Right, so place yourself in the boots of a first responder arriving on a dark city street. You find a patient lying unconscious on the sidewalk. Their skin is turning blue. They're actively dying from hypoxia.
But they have no ID.
No ID, no family present, and you have absolutely 0 access to their medical history.
You have no way of knowing if they have healthy lungs or advanced COPD.
Exactly. So how does that paramedic, in a fraction of a second, weigh the desperate, immediate physiological need to force 100% oxygen into those lungs to save the brain tissue right now?
Against the terrifying, invisible risk that this specific stranger might rely on that very hypoxia just to keep breathing.
It's an impossible tightrope walk.
You're forced to treat the immediate, visible threat to life, knowing full well that your intervention might trigger a secondary, hidden crisis.
It embodies the heavy burden of emergency medicine. Every single decision is a calculated risk balanced on the edge of a knife.
And to think, we started this deep dive talking about movies where they just casually slap a plastic mask on a patient's face to make the scene look dramatic.
It's a bit more complicated than that.
Just a bit. It turns out the reality of that simple piece of plastic is infinitely more complex and honestly, far more heroic. Thanks for taking this deep dive with us.